Hey everyone. Today we're releasing finally this Thomas Michaud podcast. So Brett and I got to spend a good day with Tom in Boston almost a month ago now. Geez. Man, what an awesome day it was getting to see him at his workshop and his clinic and all those types of things. And I think, one big takeaway for me is just like the importance of understanding anatomy, understanding the biomechanics of what's happening when we're walking, when we're running, when we're doing the things that we're trying to do. And that directly links to us prescribing, we talked about orthotics, prescribing exercise, all those types of things. So Brett, what was your big takeaway?
I think to those points, we obviously, no matter where we are in the body, we are always preaching a multimodal approach. So Tom has always done that. So even from his first book, which was called Foot Orthoses, he in that book he talked about the importance of treating soft tissue, the importance of rehabilitation exercises. He's got a section on manipulation in there, and then how to integrate it. So I think that was always good. And that's always going to resonate well with us, I think. I think also on the biomechanical side of things that you and I are going to come across a case where even if the treatment is going perfectly, we don't have an answer for the case. So that could be a structural foot problem. Maybe it's a functional hallucis limitus. Maybe it's an uncontrolled pronation problem at the rear foot. So I think what Tom basically reiterated was, it's really not necessarily the orthotic in itself that's making the change, especially if we're talking about tibial rotations and things like that. It's the actual postings. So, and what Tom has basically done is he's trying to make it, an area that's really difficult a little bit easier by giving these stick-on posts that we can play around with, and we can, as long as we've trained our eye well, that we can put these in the right spots and can control pronation or do other things in the forefoot also.
I love it. And this is part one of our conversation that we sat down with him for almost 2 hours. And so we split up into two. And so the first one, we get into his books, his biomechanics, stuff like that. But maybe one thing that we're still contemplating or still kind of trying to work through does it fit in, does it not, something like that would be for me, I guess, the idea of training single muscles, maybe single joint muscles, training them open chain. He's kind of a big proponent of just like, for example, strengthening soleus. And now he's not big on like how we do that, but I think we would maybe choose more of a global approach, a DNS position to do that, whereas he may be doing just straight muscle strengthening. Mm-hmm. So I think it's still, the research tells us to do that. However, I think that there's better ways around it.
Or, could it be one of those things also where, like we may do something specific, non-functional for like a tendinopathy or something like that. Maybe, parts of it could find their way in the model. That's why we're still contemplating it. And I think the other thing would just be, Tom's got gadgets. Tom's a genius. So, how do the gadgets work for us in practice and into utility? I think there's something there. We gotta sit down and we gotta try to figure it out. So
awesome. All right, guys. Well, enjoy part one of this conversation with Tom Michaud, and be looking for the second one. All right, everybody, welcome to another episode of the Gestalt Education Show. We're expanding on our clinical Savant series today with Dr. Tom Michaud. We're here in, it's not Boston.
That's Newton,
Massachusetts.
That's
Brett and I just got in today, and we got an awesome tour of Tom's office and some of the awesome things he's working on in his little workshop over here on the bench. And so if you're tuning in just on the podcast, there's a video portion of this as well on our YouTube page as well as Instagram. And so Tom might pull out some stuff and do a couple things. But for the man that really needs no introduction, Tom is a chiropractor by trade. Tom is an author, I would say a world-renowned author. He's one of the best biomechanists in the world when it comes to the lower extremity, honestly throughout the whole body. He has got two of the best books in the world. So Injury-Free Running was kind of like the first one that really took it off, right? And then Human Locomotion, which it was, that was the one that when I was in chiropractic school, it really made me understand anatomy. It made maybe understand how we've gotten to this point as
before that there was foot orthosis.
You're older.
Yeah.
It's really going back. But so anyway, we thought maybe, Tom, if we start by what was your main influence on starting writing, and then what most people don't know is that you actually illustrated all of your books as well.
Yeah.
And so where did the feeling of needing to start writing come from?
Well, probably like mid 80s. I was working with my brother. We were going to open up an orthotic laboratory for chiropractors. So I started lecturing locally. I'd have a lot of people come in here. We would do a series. And I thought lecturing isn't that efficient. And as we've talked about, I don't like it that much. It's amazing I'm even here doing this. I like this guy so much. I started saying, well, I'll just write a small journal on biomechanics, like certain graphs. It was supposed to be this kind of short little 30-page thing. And then 4 years later, I was still working on it, and it turned into my first book, Foot Orthoses and Other Forms of Conservative Foot Care. And Williams and Wilkins published that. It ended up going into 4 languages, which was pretty neat. And it was really read mostly outside the chiropractic profession, which surprised me a little bit. But PTs loved it. Australian podiatrists loved it. And after that, I just got in the habit of writing. Whenever I got a complicated patient, I would write a case history on the person, like we were just talking about. You learn a lot when you write. The illustration, I've just always been able to draw, and I like it. So it was like a perk on top of it, but it really helped my writing. If you can illustrate, it makes a world of difference in biomechanics in particular, because these things are complicated. You can't say that as the rear foot everts around the longitudinal axis, the first rate dorsiflexes and inverts. It just doesn't do it for you. But if you have a picture of it, it makes sense. So it was just a nice thing that I could illustrate. But I just started after that. I did a lot of case histories. I published a lot of stuff on difficult patients. And like I said, you learn from it. I did a bunch of stuff on vertebral artery dissection, on shoulder injuries. I'm still doing it. The athlete that I just had with an adductor tear, I'm turning that into a paper. And then just last week I finished that paper on hypertension and isometric exercises and diaphragm exercises. There's a lot of weird information out there that's fascinating that gets missed over by mainstream medicine. And guys like you, like 10% of manual people, trainers, PTs, chiros, they want to get good stuff. And I have just always been fascinated with it. I don't do it for work. I find the stuff interesting.
I think, what people are most fascinated by you, like that have heard you talk, is you're able to recall research really well. I'm just curious, how do you find all this research? Like, are you...
Well, at this point now, I've got a lot of friends from all over the world where if they find something interesting, they send it to me. If I find something, I send it to them.
Sure.
And, I get all the abstracts from MedSci Sports Exercise, Scandinavian Journal of Sports Medicine, American Journal of Sports Medicine. So there's like 15 major journals, Foot Ankle International, where you get abstracts, and it's never been easier. When I wrote Foot Orthoses in the 90s, I had to go to Harvard Conway Library, look up references, go pull them off the shelves. It was 1 day a week that I had to take off of work to do photocopy. They had like 15 machines. You could put your credit card in the machine, and I had a wall full of journal articles, and you had to remember them. You couldn't say, I'm just going to do a search in my D drive. You had to remember. That's why people think that I've got this freakish memory. It's just I got in the habit of saying, okay, that article was here, and it said this. So now when I do get articles, I file them under different headings so that I can pull them up quickly. If you find something on diaphragm and hypertension, you don't put it under diaphragm, you put it under diaphragm and hypertension. So, or rear foot post control, decelerate velocity, because every journal article has something different in it. In fact, there was just a paper that came out, Ferris did it. He did tibial nerve blocks. He took athletes, put them on treadmills, and paralyzed their intrinsic muscles by doing a tibial nerve block, so only the planar intrinsics were paralyzed. He put them on the treadmill and told them to walk, which was awesome. And what he showed was that the arch didn't drop any differently. So they said, the intrinsics don't control motion during contact and mid-stance, because there was no change in contact and mid-stance activity whatsoever. But when they went into their propulsive period, they couldn't. So because the toes couldn't pull down, the foot started to splay. So they terminated their propulsive period early, They turned the treadmill up a little bit, it started going faster, and the people just compensated by having this slappy push-off with an increased cadence, but they could come close to the same speed. But in that paper was a reference that I loved, and I had never seen before. They showed that, you know, the cutaneous receptors on the bottom of the feet, Meissner's corpuscle, Pacinian, once stimulated, cause immediate contraction of the digital flexors that offload the metatarsals. That research was done in the 80s. If you put an irritant, that's why people who are barefooted, they push down more with their toes because they feel an irritating surface, and that causes them to fire their toes. So I've always felt like the intrinsic or the Pacinian, the skin receptors, were incredibly important. This guy took Novocaine and did a block every quarter of an inch along the entire bottom of a foot, and then told someone to walk, and they walked just fine. And I thought, that's kind of good, because they always felt that people who were older fell because they had decreased plantar cutaneous receptors. But I think, and as you get older, you lose 70% of those, and there doesn't seem to be anything you can do to stop it. So when I saw that, I was like, well, that's good. So that means that people aren't falling because of lack of cutaneous receptors. It also explained why there's all this research that if you put irritating insoles on the bottom of a shoe, you'll increase people's proprioception because they can feel the ground better. But they've never consistently done well in research, although I've used them on occasion. Balance Pro is a company that makes them. It has a ridge that goes around the outside, and if someone starts to lose their balance, they can feel that ridge and then bring themselves back. And I got okay results with that. But after reading that if you block the receptors with Novocaine, that they could still move, it made me think of the early research on ligaments, where everybody said ligaments have special receptors and Golgi tendon organs, other things, and they tell you when they're under tension. And then they showed when they did nerve blocks to those, people still had good proprioception. Most proprioception, in my opinion, comes from information from the annular spiral nerve endings, from the muscle spindles. When you hit something, your foot moves a little bit, the spindle picks that up. Spindles pick up everything. They tell you acceleration, they tell you velocity. Tension in a muscle can alter spindle activity. If you foam roll a muscle too much, you'll stretch the fascia. Spindles are embedded in slow twitch muscle fibers, and they're embedded in the fascia and the perimysium. And if you loosen that up too much, you'll kind of deafen the input from the spindles temporarily. That's why if you foam roll aggressively and then play sports right away, you won't have as good proprioception. So, like talking about foot ankle, when I saw that, I started doing more rock board exercises, I started doing more strengthening exercises to stimulate information from spindles. Spindles only, and I didn't know this until a little while ago, spindles exist in slow twitch muscle fibers. Slow twitch muscle fibers need oxygen. You increase someone's aerobic capacity, you increase their aerobic fitness, you will increase their spindle awareness, you will increase their proprioception. Proprioception to me is lack of proprioception is the number one cause of injury in people. And it can be caused by a lot of things. People who are hypermobile have difficulty accessing their spindles. People who are hypomobile have difficulty accessing their spindles.
Well, shoes, man-made surfaces, those are probably contributing factors also.
Anything that limits motion.
Right.
Yeah.
So in all your books, there's kind of a theme of talking about evolution. You kind of start all your books, getting back to that. Can you let our listeners kind of know, or the people who are watching us on video here, why you feel like that's important? Because you feel it's important enough to put it at the beginning of all your books, which says something. So yeah, can you tell us a little more about that?
Yeah, it's funny. I just did another edition of Injuryfree, and the only chapter I took out was the evolution chapter because I didn't think people were interested. I personally find it fascinating, but most of the people that were reading it, I think, kind of skimmed through it. Except people like you, who if you want to understand how the human body works, you look at how it was developed over the last 4 million years. In fact, I did a paper, went in Foot Ankle International with Ward Gay. He's a phenomenal researcher, is at a medical school in the Midwest. He's the guy who showed that hypermobility of the first ray predicts the development of hallux abductor valgus, of bunions, and that he created a machine that measured dorsal displacement. But then he also showed that people who have hypermobile first rays, who go on to get hallux valgus, also have thumb radius indexes where they're loose here. So he asked me to help do a chapter or do an article with him, and my contribution of it was the evolution of the first ray. 4 million years ago, tibialis anterior attached proximal to the medial cuneiform and in Lucy, and then it gradually shifted forward as our stride length increased, so it could create a compressive force that locked the first metatarsal into the cuneiform. And to me, that showed like a perfect example of how anatomy like unrelentingly modifies itself to make for more efficient gait. And that's what fascinated me about the study of evolution, because it applies to, once you understand that, it's all about not utilizing calories. That's why I personally was never a big fan of the born to run movement, because running is not metabolically that efficient. A researcher at Harvard named Bewiner showed that quadricep lengthening under tension, when you walk, your knee is extended when it hits and it flexes 20 or 30 degrees. When you run, it will hit at 20 degrees flexion and then flex up to 45, 50, absorbing up to 8 times body weight. And Bewiner showed the metabolic cost of decelerating knee flexion is so great that it's 5 times greater than walking, that you'd be too metabolically, it would be too expensive to run as a way to get calories.
As Tom says, only avoiding marooting elephants and bees, right?
That's a good one. Those guys were funny. They were in sub-Saharan Africa for 30 years. And they said, we never saw local people running for food sources. But it can be done, that where you run to exhaustion in the heat. I mean, we're really good at heat dissipation, so it's possible. I just didn't think it was really common, because we're just so efficient at walking. And we burn hardly any calories with walking. In fact, we were just talking about it. I just did that paper on hypertension. American Heart Association says if you want to drop your blood pressure, you should walk and swim. And a paper came out showing that walking only lowers systolic blood pressure by 3 millimeters mercury. It's just not stressful enough.
And people don't lose weight walking either.
No. There's that great research that came out at Scientific American a year ago, December. They looked at the metabolic cost of locomotion and determined that you do not lose weight by exercising at all. And what they did was, these paleoanthropologists spent years with gorillas and chimps, and gorillas are like 3% body fat, they never get diabetes, they have low cholesterol, they don't get hypertension, and they never exercise. They wake up, they walk like 5 feet to their food source, they eat, they go back to sleep. They burn next to no calories, yet they're solid muscles. Human beings, on the other hand, if we don't walk 8,000 to 9,000 steps per day, we fall apart, because for 4 million years our DNA was programmed to require exercise in order for the DNA to be read properly. And they said, the great paper, my favorite part of it was that they said exercise isn't optional. It's required for our survival. Like 60% reduced rates of cancer, 70% reduced rates of cardiovascular disease.
All systems of the body.
All systems of the body. And how little exercise did for weight loss. They talked about that as well. Because years ago I used to have like high-level women coming in, and probably half of them were on thyroid medication. And no one knew at the time, but I couldn't understand it. Why are they hypothyroid? They're running 100 miles a week. About 15 or 20 years ago, they showed if you exercise too much, you develop a protective hypothyroidism, where your central nervous system says, you're spending way too many calories doing this, so when you're not exercising, we're going to shut the system down, because you're just costing us too much. And that gets into the whole process of evolution. It's all about not spending calories. So if you did, because a couple of endocrinologists started training these people, and I sent them the paper saying, no, this is protective. So it really shows your system adjusts for your exercise. That's why exercise is not an efficient way for losing calories.
Well, I think that paper by, was it Schnorr or whatever? I think Schnorr, where they found, you talk about like running in moderation, where, there's that window. If you run more than 25 miles a week, then all the benefits of running then went away. But you could add 6 years to your life if you ran, I think it was more than 5 miles a week.
Man, you're good. I didn't even remember. Sometimes I'll pick that book up and go through it, and I'm like, wow, wow, that's impressive. I was thinking about getting older. I forget half the stuff I wrote. So.
But I think like it's a testament to moderation. And I think like that's what people want to know. It's like, okay, can you just tell me like how much running's healthy? I think we know that there's definitely like a point where running can be harmful. You know,
the stat for that was if you run 5 miles per week, you live 6 years longer than a non-exerciser,
right.
Which is nothing. If you ran more than 25 miles per week, you lost that 6 years.
Right.
And then another paper came out that supported that. They showed that the non-exercising spouses of marathon runners died at the same age. So, distance runners don't like when I throw that out there. It's like, don't shoot the messenger. Right.
So I think you and I are definitely fascinated by the energy storage mechanism of our tendons. I think like with me dealing with like the throwing athlete a lot, like that is such an important thing that I think people aren't talking about. In saying that, what can we do as clinicians to maybe help with the resiliency of our tendons? What's the latest research? What do you think?
If I didn't know better, I would think you fed me that question because I just wrote a paper on it. You read that, I bet. That was nice of you to throw that out there. Thank you. So that's what we were just talking about in the new edition of Injuryfree. They have shown that there are positional tendons that are proximal to the knee or proximal to the elbow, and then there are energy storing tendons that are histologically different. So downstream from the knee, tendons, when they lengthen, for example, Achilles or flexor digitorum longus, the fibers separate by as much as 11% and then spring back, giving you free energy. Proximal tendons, they're also long. If you look at, say, flexor digitorum longus, the muscle belly is short, the tendon is really long. So that 11% over that length, it's like bouncing a super ball. It's all free energy. The proximal muscles like glute, adductor magnus doesn't even have a tendon. Sometimes the muscle just blends into bone itself, but most of those tendons are 1/4 of an inch long, and they're just for transferring force. So their morphology and their histology has been defined by whether they're going to give you free energy or whether they're going to generate force. They just published a paper showing the sprinters, when they do MRI studies of volume, they've got larger glutes, they've got larger hip abductors, the muscles themselves are larger. The best marathon runners have got stronger, more resilient soleus muscles. So what they have done, they've shown as you age, you get cross links between tendons, and David Seaman points this out beautifully. If you have a bad diet, you have, say, too much sugar, too many carbs, you have advanced glycation end products, which get caught between tendons and make them sticky. Very low density lipoprotein particles get stuck in between tendons. High cholesterol people are more likely to damage tendons. So you want to have a good diet to make sure your tendons are supple. But they have also recently shown that isometric contractions held with the muscle in a lengthened position for 30 seconds to a minute increases tendon resiliency. So I take every athlete now, like I made that toe pro foot strengthener to strengthen the intrinsics and all this other stuff, but at the end of it, after this research came out, I have them drop their heels down, and if I want to get peroneals, I'll have them invert their feet, their toes are cocked back, and then I'll have them either hold, they can push against something over their head, I'll do it under a pull-up bar, they can hold the weight, I'll have them hold that to failure, whether it's 60 seconds or 2 minutes, because prolonged isometric contractions, that paper I just wrote on blood pressure, they did one study where they showed people who were exposed to occupational stress, where they had to do isometric force, like plumbers where they would grab things, have way lower levels of blood pressure than anybody where they don't have isometric contractions. And all they did was they had people do hand grips at 30% full force for 30 seconds. No, it was 2 minutes, sorry, and they did it 4 times. They had up to 15 millimeter drops in systolic pressure, and that's what we were just talking about. That kills 15 million people annually, hypertension related stuff, but it's related to tendons. You put it in a lengthened position, and Injuryfree, to make runners more efficient, I came up with a series of exercises, like a supine hamstring lift. You hold a physio ball out, the person's out on their back, they have one heel on the ball, then they raise up so there's 30 degrees of hip flexion. It correlates to the exact position the thigh is flexed during initial contact, and then they isometrically hold that there. At first you can do it at 30 or 40 seconds. I do it until they start to shake. When the muscle starts to shake, you're making that shift from slow twitch fibers, which are highly coordinated. One nerve will innervate like 200 or 300 fibers. They make the shift to fast twitch fibers, where one motor nerve will go to 2,000 fibers. So it's not as coordinated. So you visually see that shift. Nick Studholm talks about the muscle oxygenation sensors I'll sometimes use for that. But I wait until they shake and I have them hold it, and I'll have them do that 4 times. That increases tendon resiliency. And the beauty of isometrics, and this is kind of cool, it relates to that study out of Brown University, and you're familiar with it. They took turkeys, put them on a treadmill, they embedded strain gauges in their tendons, their Achilles tendons, and in their gastroc, then turned the treadmill on. And they showed that right before a turkey goes into its propulsive period, the gastrocnemius and soleus isometrically contract to lock. So it's locked, they're going forward into propulsion, which is stretching that tendon that extra few percent. And then when they go into propulsion, that free energy comes back, and that gets back to evolution. You do not survive as a species if it costs you too many calories to get to a certain spot, because it's all about the metabolic cost of locomotion. If you get free energy from tendons, the world's best runners, I've treated Kenyan, Ethiopian, I've treated African runners for almost 40 years now. Almost every one of them has an Achilles tendon that's this long. And the world's best runners I see, they have longer tendons, and they've shown that. Length of tendons correlates to efficiency, and you have to maximize efficiency. And isometric contractions with muscles in their lengthened positions, and angle specificity. You want to get them in that angle that it's going to fire in. For example, I play a lot of tennis, and I want to increase the speed of my tennis serve. So after reading that research, I took a dumbbell, I put 30 pounds on one side, I lie on my back, I have my palm like this, and then I'll pronate my wrist and hold it isometrically until I fail. And then I'll take my other hand and I'll pull it down. I usually fail in 30 seconds. I do that 4 times, 3 times a week. It increased the speed of my serve probably 15 miles an hour. Which, I'm getting old, so that was a nice little perk. Plus, my shoulder feels better, because where I hit that ball, I'm stronger now.
Have you seen that paper where they looked at serving and forehand improvement with allowing the athlete to grunt? So, yeah, so I mean, I think there's so much there from a core standpoint also.
They also showed a different sound they made improved performance. If they made ahs, it made they had a more force output. So they looked at specifically glottal closure with that paper, and they showed certain sounds produce greater force output. Ah being the best. I just hate being near someone on a tennis court who's doing that.
Monica Seles, remember her?
She was awesome.
Yeah. She could smack a ball.
Oh, yeah.
It's amazing.
So then you think then for our runners, back to the resiliency of the tendon, we should be doing preventative programs for tendon, or do you think?
Yeah, without a doubt. The tendons that do the most work, Thalen showed that as the leg is swinging through the air, just before heel strike, biceps femoris isometrically contracts, then the leg goes forward, and that allows for the storage and snap back return of energy. The same thing happens when you go into your push-off phase. So I do the isometrics on biceps femoris. I then have them get into a push-off position. I'll do it on the toe pro or anything else, and I'll have them do it on their gastroc soleus, where the heel is down, the ankle is dorsiflexed, and usually they'll go from slightly supinated to neutral. And then I'll have them go with their toes too, because they've shown the fastest runners, especially sprinters, have the strongest toes. Toe strength predicts agility, it predicts sprinting speed. It also offloads the Achilles tendon. They just published that paper we talked about. After Achilles tendon ruptures, treated non-surgically, the people who had the best outcome had the thickest flexor hallucis longus tendons. And they showed that after Achilles injuries, flexor hallucis longus hypertrophies 15 to 20%. So it's that force transfer. Root talked about it in the 70s. You can produce a heel lift in a patient with a ruptured Achilles just by using flexor hallucis longus and flexor digitorum longus.
And I think too, our students and even our doctors, they sometimes there's a little bit of confusion of we don't want clawing at the digits, but the ability to press our toes is a different story, and that's actually beneficial. And Tom and I were talking earlier about the overly pronated medial longitudinal arch. if you are the proud owner of that foot type, if you have strong toes, then that is like one thing you can do to maybe safeguard yourself from the consequences of overpronation.
There was another important factor about the angles you were talking about. If you just do a short foot exercise or any of the standard things where your toes are in a neutral position, you don't get significant strength gains. A study out of Australia showed 6 months of doing those exercises 3 times a week, physical therapy supervised, produced no change in toe strength. Then Goldman did that paper where he cocked the toes back 45 degrees and had them isometrically contract, 4 times the strength gains. And we had talked about performance agility correlating exactly with toe strength. It didn't correlate with toe strength measured in neutral. It correlated with toe strength measured at 45 degrees. When you're changing direction, your heel is off the ground, the toes are the last thing you're on, and they're cocked back. So angle specificity, you want to get stronger, those toes have to be cocked back. You know, that's why the toe pro thing has the toes coming back. But whenever you do toe exercises, they have to be muscles exercised in lengthened positions get stronger quicker. It stimulates satellite cells. Nobody knows why. But I only do, like if I'm doing a glute med, I don't like crab walks and stuff because everything's in a shortened position. I want it lengthened. I want it lengthened to neutral. I want that, which is how it fires in real life. If pelvis is within 4 degrees of level, drops down, it's a lengthened position that it's in.
We found that a lot with DNS exercise, especially our sideline exercise. Like we'll put the muscle under eccentric tension, make them activate there. It's funny, we kind of come to the same conclusions.
Well, this is really cool. This guy, Anthony Kay, talking about eccentric loads. Best paper ever published on injury prevention. If every pro athlete did it, the injury rates would drop 99%. He took athletes.
Well, hold on, let's make him pay for this
now. He took athletes, put them on an isokinetic machine, leg straight for knee extension, and then overloaded their ability to resist. So he said, you resist as much as you can, and he went beyond it. So he went to 30 degrees. I think he did like 5 sets of 12. I'd have to look it up. At the start of the study, there was a control. They ran downhill, they measured tendon resiliency, they measured quadricep diameter, but also the ability of the tendon to store and return energy. After 12 weeks of doing this, when they ran downhill full speed, they had huge drops in creatine kinase levels. They had no eccentric damage to the muscle. Their tendon resiliency improved, shock absorption improved. It's just not done. I do it with rotator cuff. I don't do it because I don't have an apparatus to overload. And I emailed him and asked him like what the injury rate with that was, and he goes, fine. Like, and it probably would be fine with athletes, but I'm treating older people now. So I do it with where I'll manually overload them, and I'll show them how to do it themselves at home. So I'll have them resist a movement. So if someone's getting hurt with a backhand or something, or like a certain angle, I try to duplicate the angles where they're getting hurt. But I really, like you, I try to emphasize strengthening in a lengthened position.
So, over the years, I think we've kind of come to the conclusion that maybe pronation, and we know pronation is not a bad thing, but that the look or the cosmetic look of overpronation might not be the problem. It's more the angular velocity or the rate of pronation. That brings us to another really important question of like us who are in the trenches. What do we do from an orthotic standpoint or like rear foot posting? Do we have an effect? You and I have had a lot of good discussions on this. I think when I was a student, the debate that continued to rage on was we knew that subtalar eversion was a coronal plane movement that was driving internal rotation of the lower shank, and everyone kind of debated, and then that one paper came out. I don't know if it was Lundberg, I don't know, but anyways,
good one,
but that it's it just depends on the patient. There was all these variability in it, and can you maybe speak on like what's the latest and greatest as far as we know Inman's model, the mitered hinge, that's kind of been, it's not exactly what it is, but then yet there's things that are telling us that maybe it is. Could you speak on that for us?
Yeah, good question. Inman's model was that 1-to-1 mitered hinge analogy. So for every 1 degree the foot everted, the tibia internally rotated a degree. So you're looking at 10 and 10. And what they later showed when they developed techniques where they could put tantalum beads inside the talus and calcaneus and then have people move through ranges of motion, that the subtalar joint isn't a torsion transmitter, it's a torsion dissipator. So that's why pronators don't get knee injuries at the rate they expected. So if someone who has a low arch, has a low axis of motion, they'll evert 10 degrees, but the tibia will only turn in 8 degrees. But someone with a high arch will evert 4 degrees, but they have a high axis of motion, so the tibia will turn in 8 degrees. So they ended up with the same degree of tibial rotation, independent of foot architecture. And what they're really showing is that it's the velocity that causes it, pronation-related injuries, and strength. They have shown that strong pronators, which is why that barefoot craze has done a lot of good. Like if you wear minimalist shoes around the house, and for most sports, not long distance running, they've shown that good long distance runners are more likely to be injured if they wear a minimalist shoe, and they do better with some slight heel elevation. That was a study, MJ Sports Medicine, over 500 people in it. But getting back to like the benefits, minimalist shoes do strengthen your arch, and pronators with strong arches are way less likely to be injured. They also did a study, we talked about it, that pronators who and neutral people who are given foot strengthening exercises, the pronators improve more than the people with neutral arches because they're more reliant on intrinsics. They have a mobile foot, so their midfoot has to absorb force. Just like that study where they did the nerve block on the intrinsics, you can't go into your propulsive period if you're not really strong. And what people don't get, pronation causes your foot to drop in, and that's bad. But you're off of an orthotic during your propulsive period. You're just on your toes, so you're going to need
really
strength.
Good point. No one ever talks about what he just said.
You're going to need strength in your intrinsics. The bottom line. And lack of strength in the intrinsics correlates strongly with the development of plantar fasciitis, correlates strongly with the development of hallux valgus. 1 in 6 people who go out for bunion surgery have bad outcomes because not a single surgeon ever checks strength in toe muscle.
Oh, that's the worst. It's the most failed surgery there is.
Oh, yeah.
Yeah.
Mm-hmm. Especially if I do it.
The surgical suite is back here.
Yeah. So you've kind of, came out with your rear foot posting. You might hand me these, Taylor. And I had been wanting to play around with these forever. Originally, the thing I always was thinking about is if you had something like this, and then you could play around, because I myself was getting kind of frustrated with the castings and stuff. And the research is showing that like there can be a lot of erring, the debates on subtalar neutral and casting that continue to rage on. Why not like just being able to eyeball what you're seeing, put something temporary in the shoe, and then give them a trial of care or a period to try it, and then that would tell you how well they're doing. Then you could make a permanent orthotic off of it. But anyways. Is it as simple as, why don't you just kind of tell us how you use this? Yeah, that might be the easiest.
For starters, this came about because I read a paper 15 years ago by a guy named Joseph, and you had a really good point about the controversy. Who do you post? When do you post? What size post do you use? And Joseph, because he's a researcher, said, I'm not even going down that road. I'm just going to give this post to everybody. So he took people with valgus collapse, and he posted them 5 degrees, which is just an angled wedge that tilts up on the medial side, supports the medial side of the foot, and then had them do drop jumps. Significant reductions in valgus collapse, independent of foot architecture, which is kind of interesting because Novoselsky, who I know, and some other people have shown that pronators sometimes, if you post them, will roll over the top. If you put an orthotic that controls them, they sense it and get annoyed by it and roll over the top of it. Like you put a lumbar support on someone and they're like, I'm going to lift this thing no matter what. It's not as protective as you might think. Like knee braces don't protect against ACL injuries.
Right.
So after I saw Joseph's paper, I started treating people, because orthotics weigh a lot, they're expensive, they're bulky, you got to know what you're doing, otherwise you got to send them back to the lab all the time. So what I started doing was just grinding crepe posts and gluing them to the bottom of insoles. Time consuming, I didn't like doing it. I started sending it out to labs. It cost too much. So I had a guy I know in the Midwest make these, and first I'll talk about the paper that made me make them. This researcher about 2 years ago did a great study. He took a conventional over-the-counter orthotic that was unposted, like this, right? And then measured 3-dimensional motion, tibial adduction, abduction, tib shank rotation, the speed of motion, extremely detailed. And machinery is getting better, so the research is getting better and better. So he measured motion and determined that a 0-degree over-the-counter orthotic distributes pressure well and can enhance proprioception, but it didn't alter tibial rotation effectively. It didn't alter motion in the femur well. So then he took the same orthotic and put either a rear foot varus post alone, a rear foot and a forefoot post, or nothing. And he showed that when you added the posting, all of a sudden the orthotics, a varus post stopped the tibia from abducting. It stopped the femur from shifting. It altered valgus collapse. It decreased internal rotation. It decreased the velocity of motion. So it turns out it's not the orthotic that's most efficacious, it's the post. So when I read that, for years I've been meaning to make up my beef with the full-length posts, is that they're thick, they're heavy. There's that 1% rule, I don't know if you guys know it, for every 100 grams, which is 3 ounces, you add to the bottom of a shoe, you increase the metabolic cost of locomotion by 1% because the hip flexors have a long lever arm to fire against, so they have to work harder. So I wanted to make a post. My first models had holes drilled all over them, but then they caved in and were difficult to make dies out of. Then I just made this model that is a 4-foot varus post because I don't want to support the arch. The arch can do whatever it wants because it's got the flexor digitorum brevis and abductor hallucis to protect it. It doesn't want anything lifting into it. In fact, a paper just came out that showed if you do an orthotic that comes up high beneath the arch, within 12 weeks, they got 17% atrophy of abductor hallucis and 11% atrophy of flexor digitorum brevis. So the last thing I wanted to do was support an arch, especially in a high-level athlete, because both of those correlate with injury, Achilles injury and plantar fascial injury. So I got rid of the arch component of it here, and then I made a rear foot post that goes here, and then you just peel it off and put it on, you're done. And you don't have to put it on an over-the-counter orthotic. I put them on the bottom of insoles. And at first I thought I'd do what you do. I would do a trial and see how it works, and then I just leave it at that.
They're holding up permanently.
It works.
Patients will love that. It'll be cheaper.
It lasts a long time. It lasts 2 years, and I determine who gets them by the medial drift test. I put talonavicular neutral. I see how far the talus adducts and plantar flexes with that little device. I'll give you one. It's great. And if they go over 10 millimeters, I will put a varus post in there because varus posts were shown to alter inversion moments. And what you are measuring with that device is an inversion moment. So just a really simple way to do it. The old-fashioned way is to look at frontal plane bisection of the heel. Frontal plane motion only explains 17% of all force output during the gait cycle. So why measure it? So when you're measuring, and this is really fascinating, because once you use that medial drift enough, you'll get people whose calcanei hardly move at all in the frontal plane, but the talus will spin like this and drop down, and you'll see the knee turn in. They'll have a high medial drift. They'll get a varus post. If all you did was look at the frontal plane bisection, you never would have used the varus post. The old-fashioned way is to go, oh, the calcanei are everted, and it needs support. And I don't look at how even.
But they missed that one even. I mean, I think that's where this is exciting. Like, I think like sometimes like people are raising a medial longitudinal arch on like the rear foot valgosity problems. When if they would just post the rear foot, leave the arch alone. Yeah. But people like for some reason they cannot distinguish the different areas of pronation, whether it's a medial longitudinal arch or the rear foot. Brings me to this important point that me and my friends, we always debate a certain foot type, which is the high arch cavus foot. Okay. Now the interesting thing with us that are trained in joint play, that foot we obviously find a lot of restriction in the midfoot, the mid-tarsal joint, the Lafranc joints. All those joints get blocked, and we manipulate them, of course. But the weird thing is to look at it cosmetically. They look obviously like the rear foot inverted, but those of us who are joint playing, we always come to the same conclusion. If you joint play subtalar joint eversion, they're ironically hypermobile there. I had this conversation with Michaud 10 years ago. He takes that foot and he actually does a rear foot post into valgosity. Mm-hmm. But the reason I've never been able to like be okay with that is just because I know the joint, to me, like when I joint play it, it's like it's sloppy, right. You know? Right. Can you talk about management of that foot? Because I mean, we've debated too, like in orthotic management, whether you would post underneath the medial longitudinal arch. And there's a Bedorthus. I think you've met Sean Ito before. And
I just did a thing on the other day.
And him and I, we used to talk about like then you could put a post under the medial part of the calcaneus. Then you could post the forefoot into valgosity. That way, they're not literally just walking in more of an inversion ankle sprain.
Right.
Do you understand my question? It's kind of because like McPoyle offered a solution that I thought in my mind didn't make sense, just because I felt like some people, they're just looking at it, and I get that. But then like once you start joint playing, then you're like, my God, this is like so hypermobile. Does it really make sense that I would want to just,
Well, what you're talking about is when you get someone with a cavovarus foot who also has a tibial varum. Mm-hmm. They will have hypermobility in the frontal plane. The subtalar joint will evert more, and that foot type, I strengthen their ankle with ankle rock boards. I'll do strengthening, manipulation, make sure the gastroc is loose. But say they had a cavovarus and a neutral tibia, I don't find huge ranges of eversion in that foot. If they have a varum, they're going to have that huge range because they have to get their foot to the ground. Mm-hmm. But anybody with a straight tibia or a slight valgus, I will put a full-length valgus post beneath them in addition to manipulation. Manipulation then with them is key. They've shown that cavovarus people don't balance well. One of the theories was that they have less contact with the ground, so they don't feel the ground as well. If you look at a footprint of a cavovarus person, they don't feel the ground well. A hypermobile, a flat foot person has poor proprioception because they have hypermobility and their center of mass, their medial malleolus has drifted so far medially, it's too far of a lever arm to get them back. So they don't have that balance where they're fine-tuned. So they get it for different reasons. But if it's your type of person with excessive eversion and a rigid foot, I will treat it all with strengthening mobilization, enhances proprioception. They did that paper, JOSPT. All they did for ankle sprain people was mobilize. Huge increases in balance, huge increases in anterior reach. But if it's a neutral foot and they're getting even a hint of medial knee arthritis, just like a varus post can alter movement of the tibia where it can redistribute pressure through the knee in the frontal plane, a valgus post can cause the tibia to abduct, which opens up the medial joint side of the tibiofemoral joint, so you can offload someone with medial knee arthritis. So say you have a patient in their 60s, cavovarus foot, the beginning hint of medial knee OA, you see a little bit of puffiness around the plica.
Pezensarine, bursite,
Yep. Mm-hmm. They studied the effect of a rear foot valgus post alone and full length, and only full length was effective. That's why you see people arguing about valgus post. I didn't make a valgus post for the rear foot only, because in Japan they did some research 20 years ago, and they showed that people with early medial knee arthritis, if you put a valgus post in them, it worked as well as high tibial osteotomies for offloading the medial joint. Because normally the medial tibiofemoral joint absorbs about 55% of the force through the knee, but when it starts to break down, it goes to 60 and 70. And what you get with a valgus post, you get, as force is peaking during contact, you get a temporary opening of the joint, which offloads it. But then later research showed, well, if you put it in a pronator, the pronating foot absorbs it, and then it doesn't protect the knee. So there was a lot of controversy. And then some people started taking Sweeto universals and putting it around a pronated person's foot with medial knee. And then they just showed the full length ones work moderately well, like 70% of the time. You had talked about before about testing, putting a post in and testing. If I put a varus post in under an insole or orthotic, I know it's going to help. I've just seen it. If it's a valgus post for medial knee, I go 60-40, it's going to help you. And then if it helps, great. If it doesn't, we'll pull it out. And it's because we're too good at absorbing shock, and to offload the tibiofemoral joint once arthritis has started is difficult. You decelerate pronation, you'll decrease twisting of the Achilles tendon, an athlete will feel better. You can offload the plantar fascia, an athlete will feel better. Kotler did a study years ago. He took a cadaver's foot, he put strain gauges in the plantar fascia, then he pushed down and loaded it with 300 newtons, however many pounds that is. And then he put a rear foot post under it, 4 foot post under it, and a 4 foot valgus post under it. and the forefoot varus post was bad for it. It lifted it up and stressed the plantar fascia. The valgus post offloaded it, so because it locked the calcaneal-cuboid joint. So they have shown that full-length varus posts decelerate, and that's what that last paper showed that I liked. It went against what I have said, and I still think I'm right. But he showed, prior research showed that a forefoot varus post alone increased pressure on the plantar fascia. And the latest research, where they measured rear foot and forefoot, showed that it didn't. It decelerated the velocity. It did a lot of wonderful things.
Now, to play kind of devil's advocate on what we're talking about, and the things that kind of, stir around in my mind are, if we talk about like the normal coupled motion of the knee, which would be concomitant internal tibial rotation with knee flexion, if we're doing things to maybe potentially block that internal rotation, could we be doing things that could be destructive? And should our listeners be kind of careful? It sounds to me like we're kind of tugging on a tiger's tail here a little bit.
That's a really good point. And that article I wrote on varus and valgus posts, I rewrote it before I sent it out to say, someone's got medial knee pain, be careful with this, because it will increase compression slightly in the frontal plane. So if someone has a lateral patellofemoral compression syndrome, great, because you're going to stop the femur from turning. But if someone's got medial joint compression, be really careful with varus posting. You can't say do a valgus post to offload the medial knee, but a varus post is okay. It's not. Right. They both do the same thing, which is why the research is so great. It makes sense. Mm-hmm. And speaking of, that was a great question about medial knee and the coupled motion between flexion and internal rotation. They showed years ago that semimembranosus has about 6 different attachment points to the medial knee, including the posterior aspect of the meniscus. And as you're loading, semimembranosus helps to internally rotate the tibia, but it also pulls the meniscus posteriorly.
Muscles are so smart.
Yeah, so as the knee is flexing, and it moved it about 1/4 of an inch. So anybody who has a medial meniscus problem, I always have them do that semimembranosus slide. I tell them, make believe there's a pile of sand under your foot and just pile it up under your table like this. So just pull it in. They adduct their forefoot. They're internally rotating. And then I have them do tons of popliteus exercises and semimembranosus. They work better for meniscus injuries than anything else in the world by a factor of 10. And I say that because I tore my menisci multiple times, and I hit a point where I couldn't play tennis. I did that protocol. All the sagittal plane stuff sagittal plane exercises do not protect the knee. In fact, they just published a beautiful paper. I didn't like the outcomes of it. It was like a 1-year study. They sent people into a gym. They monitored progression of knee arthritis as they did leg presses, leg extension, hip abduction, and they measured force, all sorts of stuff. A year of exercising did not alter force through the knee. All they did was sagittal plane stuff, and they have shown that squats, when you go past 45 degrees, increase pressure on the retropatellar joint. So, a great study. They chose the worst exercises.
Right.
They published a paper a little while ago. Gastrocnemius plays a huge role in addition to being a hip flexor. It controls transverse plane rotation of the knee. And it's like reins on a horse. Mm-hmm. So they did a study where they took people with retropatellar pain, and then in addition to all the standard protocols on the hip, they just gave them, they called it a tib posterior exercise, but it was a popliteus exercise, and gastroc exercises. The outcomes went through the roof. Like, surprise, you control the knee in the plane that it's getting hurt in. It gets hurt in the transverse plane. Control it in the transverse plane.
Tom actually showed me a sneaky way when we were in St. Louis last time at the MPI Gate seminar of how to isolate popliteus function away from the other muscles, which was kind of clever.